About the South Winnipeg Seniors Resource Council is a nonprofit information referral hub connecting older adults with community resources to assist them in our daily living. Our goal is linking older adults with resources available in the community to enhance their well-being. We acknowledge that we live and work on Treaty 1 territory, the ancestral lands of the Anishinaabe, Cree, Dakota, Dene, Ojibwe peoples, and the homeland of the Métis Nation. We commit to pursuing opportunities to make our community a better place for everyone who lives here. And with that, I'll turn it over to Rod, who is our MC, and there you go.
Well, thank you, Martin. That was a great introduction. We're very fortunate again to have another local resident here, in Danielle Sokolsky, who's a registered nurse. She's a clinical nurse specialist for the Winnipeg Regional Health Authority Palliative Care. And she's going to speak about a subject here that's really dear to my heart. I had to go through that with several family members in the past, so I understand what goes on. I would ask you to make sure that you take diligent notes. Of course, as Martin mentioned, we'll have this posted on YouTube a little later on. There'll be times for questions throughout the time frame. So if you're not willing to speak up, just turn on your chat button and I'll recognize you. And by all means, enjoy the presentation because it's pretty important. So with no further ado, Danielle, the floor is yours.
Thank you. Thanks, Rod. Thanks, Martin. So thanks, Martin, for having us come and join you today. I'm joined by Ogechi, another one of our clinical nurse specialists. She's on the call as well, so we can address any questions you have should they come up after the presentation. So as Rod mentioned, my name is Danielle Czeszelski. I'm a registered nurse, clinical nurse specialist with the Palliative Care Program. And Martin asked us to kind of give you an overview of the Palliative Care Program and the services that are offered. So I hope I'm able to do that today. Hopefully it can be pretty informal and we can kind of just have a chat after and answer any questions you have. So I thought we'd start by talking about what is palliative care, the definition. So palliative care is an approach to care that focuses on comfort and quality of life of people of all ages affected by life-threatening illness, usually at an advanced stage. The WRHA program focuses on managing physical symptoms, providing social, emotional, and spiritual care and support for individuals and their families throughout the course of their illness, including bereavement support. So I thought we could start maybe by busting some common palliative care myths. I think there's a lot of stigma around palliative care and a lot of misinformation about palliative care. So I thought this might be a good opportunity to address those common myths that we hear and that we see. The first is that palliative care is only provided in a hospital or that you go to palliative care. So in fact, palliative care can be provided in any care setting, including home, assisted living, long-term care settings, really anywhere, because it's really about an approach to care and a way of providing care. And in fact, the palliative care program is a community-based program, and the majority of the patients that we care for are at home. We have about 400 to 500 patients at any given time enrolled on program. Alternative care settings include the palliative care units. There's St. Boniface Hospital has 15 beds, Riverview Health Center has 30 beds, Grace Hospice has 12 beds, Jocelyn House has 4 beds, and we'll talk a little bit more about these care settings a little bit later in the presentation. We also provide care in long-term care settings, acute care hospitals, and in the pediatric settings. So really anywhere. Another myth is that palliative care means that there is no hope or that I and my doctor have given up. So palliative care is really about allowing a patient and family to focus their energy on the quality of life for those diagnosed with an advanced illness. And although there's hope, the hope becomes less about the cure and more about living life as fully as possible. So there still is hope. It's just a bit of a shift in what we're hoping for. And sometimes that shift happens at a point where the treatment burden of an advanced illness becomes so heavy that it starts impacting a person's quality of life. And so that's when we start to shift focus on curing and perhaps focusing more on comfort. Another myth is that palliative care hastens death. So the fact is that palliative care does not hasten death. It provides comfort and quality for those facing life-limiting illnesses, and you walk alongside patients and families until death naturally occurs. Another myth is that palliative care is for a person who is close to death. So a palliative approach to care can actually occur anywhere on a disease trajectory. So you can see here on the bottom, there's the screening process until a diagnosis occurs. Generally, that's followed by more of a curative focus, right? We're trying to do investigations and treatments to try and cure the underlying illness. If that's not possible, as the course of illness continues, palliative care and comfort care become more of a focus until there's no disease-directed treatment, end-of-life care, death, and followed by bereavement. So a palliative approach to care can be applied at any point from the onset of diagnosis. Palliative care can only be provided by specialized doctors and nurses. That's a common myth, when in fact, not all patients require the support and specialized care services of a palliative care team, and all physicians receive training in palliative care, and care needs can often be managed by the current care team. So it's similar to how everybody with high blood pressure doesn't necessarily need a cardiologist involved. It's a similar sort of idea here, is that all physicians are able to manage, palliative care and end-of-life care needs. And not all patients will require a specialized involvement of the palliative care team. So now to just kind of go over the Winnipeg Regional Palliative Care Program, there's really two streams to the program. There's registration with the program or formal enrollment on the program, and then there's our consultation service. So our consultation service consists of a team of a clinical nurse specialist and a physician. And at the request of the primary care provider, we can provide support and advice to patients and the medical team on things like symptom management issues or exploring goals of care discussions and things like that, using a palliative approach to care. So this is common in care settings other than the community, because again, people in the community are the basis of what we do. So other care settings being long-term care, acute care settings, things like that, our team acts as a consultant service to help provide that palliative lens to the team and to provide the sort of our specialty. But the patient is not enrolled on the palliative care program. We just follow, like any other consultant service, like a respirologist, see occasionally, follow up as needed type of deal. The second is registration onto the palliative care program. So this is when it is felt that a person would benefit from formal enrollment onto a program and requires the specialized service of the palliative care program. And because the palliative care program has a certain set of resources, there's specific criteria to determine who is enrolled onto programs. So we can talk about that next. So the program eligibility criteria. An application is initiated by the primary care provider or the other specialists. So that can be an oncologist, cardiologist, whoever that discussion's had with. Usually it started with a discussion about, the disease trajectory and kind of where things are at. And then it's thought that enrollment onto program would benefit the patient. And so there's some discussion around that. And then that care provider submits an application for a program. There's some core criteria for eligibility. One is that a patient is diagnosed with a life-limiting illness. The second is that a prognosis of that they have less than 6 months or less rather. That the patient is agreeable to palliative care involvement, that they're wanting our involvement. They're no longer receiving aggressive treatments, and they have chosen a palliative focused approach to care. So ACPM or ACPC. We'll talk a little bit about that in the next slide to kind of give you an explanation of what that is, and that they would not want to have life-saving measures or ACPR.
Can I interject for 1 second?
Sure thing.
Life-limiting illness. Now, aging is a life-limiting illness, is it not? So
Yeah. So frailty is one of the, can be one of the diagnoses. But there's, so once an application is received, really, if frailty is the diagnosis and prognosis is thought to be less than 6 months by the primary care provider, then the application would be submitted and it gets reviewed in a process to sort of see if they meet criteria, if they would benefit, and if it's a good fit, enrollment at that time. But you're right, that can be one of the diagnoses.
Okay.
So advanced care planning or goals of care is really conversations that are had to determine a patient's goals of care and what they're hoping for from their medical treatment. And it kind of works on a trajectory from comfort focused up to including resuscitation. So comfort focused is, as it states here, focusing really on maximal comfort, symptom control, and maintenance of quality of life, excluding attempted resuscitation. Medical level care is a care and control of a patient's condition. The consensus is that a patient may benefit from and is accepting of any appropriate investigations or interventions that may be offered, excluding attempted resuscitation. And then ACPR is resuscitation. So the consensus is that the patient may benefit from and is accepting of any appropriate investigations, interventions that can be offered, including attempted resuscitation. So again, it's kind of used to establish the patient's wishes and to ensure that the level of care that they're getting is aligned with what they're hoping for and kind of where they are at. So just a mention about resuscitation. So it's the reason why our program doesn't support resuscitation is because it's not an effective intervention in the palliative population. So CPR is intended for instances when the heart stops due to a primary cardiac problem. When the heart stops due to underlying issues that lead to the heart not being able to function, such as multi-system failure and advanced cancer or progressive respiratory compromise, CPR will not be effective and should not be offered. It's similar to, trying to jumpstart the battery in a car when the engine isn't working. So we can try to start that battery again, and we could even replace the battery, but if the engine ultimately isn't working, it's not going to result in the car starting again. So we expect that death will occur naturally, and therefore we would not attempt to stop the natural occurrence of death. And to do so could lead to an undesirable experience at end of life for the patient and the family. So having said all that, then looking back at enrollments and that picture we looked at earlier, you can kind of see the part where enrollment is sort of that red bar. We're looking at minimal disease-directed treatment, minimal to no disease-directed treatment, and really focusing then on palliative care, because that's when our team has the most impact at that point. As you can see, it's mostly blue. So our team's involvement is more of an asset at that point in a illness trajectory, and including up to death and then bereavement support for the loved ones left behind. So program enrollment, when a patient is enrolled on program, they have what's called care coordination. So they're assigned a case coordinator who's sort of the quarterback of the care and sort of the contact point. You receive regular visits or assessments by a palliative care nurse Frequency is based on needs, so it's kind of variable, and it adjusts. It can start, less frequently and increase to more frequently as things are changing. Medication coverage under the palliative care drug access program. So all medications are covered under that program when somebody's enrolled on program, and that's just to make sure that everybody has the access to the medications they need at end of life. 24/7 access to palliative team. So during the day, that's the palliative coordinator. And then after hours and weekends, there's access to an after hours nurse who's able to screen calls and offer support and guidance and triage and all those things after hours should things change. There's also after hours physician available if needed. So through the after hours nurse, you could reach a physician if that was required. Access to alternative settings of care if indicated and if a bed is available. So the palliative care units for short-term stays, and then the hospice for longer term stays. And again, we're going to kind of touch on that in a couple of slides, a little bit more about that. And then finally, bereavement support. So we have a group of psychosocial specialists that offer bereavement support. So care at home includes a lot of different aspects, and we do all these things to try and keep people at home and to keep them comfortable. Part of that is home care. So your case coordinator helps sort of work with you to see what care needs you might have at home, physical care needs, and then ADL assistance or activity of daily living, dressing, meal prep, house cleaning, things like that. So that can be coordinated with the palliative care coordinator. Symptom management, again, that would be the palliative nurse coming out for assessments, medication, training, education, and supplies. Coping and home management, so that can be done by our psychosocial support specialists and or the visiting nurses. Planning ahead, often that's done by the palliative coordinator and the nurses, having paperwork that's needed in place. I'll talk a little bit more about that in a bit. But sort of planning ahead on what to expect as things change. What is this going to look like? And kind of staying ahead of the curve to help support people to stay at home. And again, psychosocial support is available. Physician and CNS visits for complex needs and symptoms can happen. So our team is able to make visits to the home to assist with some of those more complex needs. Again, we talked about the 24/7 program access, equipment, hospital beds, commodes, Hoyer lifts, that's all arranged through the case coordinator. Medical supplies, so oxygen, catheters, things like that. And then we mentioned about the community palliative nurses making regular visits. And then education and information is provided ongoing. And this is all done with the group of, with our interdisciplinary team, which is several members of our interdisciplinary team. We work very closely with home care, again, to assist with physical care needs. Volunteers can help provide some support. Clinical nurse specialists I mentioned are available. The physician specialists are available. Community palliative nurses, case coordinators are your coordinators of care. And then we work with the patient's current team. So we don't take over care. We work with your current doctor, your current pharmacist, and your current care team, and just sort of add the supports needed to help people stay at home and to stay comfortable. Now, just to touch a little bit on the beds. So the palliative care units, if all of these interventions that I had in the previous screen of care at home are not effective in keeping someone at home, and their care needs exceed what is able to be provided in the community because there's symptom management issues or other issues, then admission onto one of our palliative care units is considered. So these are, again, for short-term stay, just like other hospitals, right? You come in, you try and manage symptoms, address any issues that brought you into hospital with the hope to bring you back home. So there's a total of 45 beds available. Again, I think I mentioned in another slide, we have about 400 to 500 patients enrolled on program at any time. So the beds are somewhat limited, and sometimes we don't have any beds available. If not, then we use a bed waitlist system, and we try and keep people at home comfortable until we're able to get a bed to bring them into hospital. Sometimes, if the patients really need to come into hospital, they do come into emergency, because that's the best place for their care at that time. We try to avoid that, but it does happen. And yeah, sometimes people do come onto our units for end of life care in the final weeks or days of life. Hospice, I don't know if any of you are familiar with it, but there's two facilities. There's one, Grace Hospice, and one is Jocelyn House. Total of 16 beds available, and that's more for those longer stays, prognosis of 1 to 3 months. And criteria for that is that symptoms have to be relatively stable. They're beautiful sites. They're both, actually, one is at Grace Hospital, like right by Grace Hospital, right on the grounds. The other one is in St. Boniface here, and called Jocelyn House, and it's right on the CN River. And the daily per diem is $30 a day. So it is a shared cost. I'm not really sure on the particulars of it, but it's sort of a shared cost. So the patient pays some, and then the rest is subsidized. But that includes all of the meals and medications and everything. It's all kind of all inclusive. I just wanted to briefly touch on a couple important pieces of paperwork that we like to have when it's required when somebody is enrolled on program, but anybody can seek this out through their care team. So one is a healthcare directive or a living will, and this is a legal document that communicates your wishes to healthcare. I have the link here. I can share it with Martin to kind of forward to you guys. It's worth taking a look at and to think ahead, and just to have, because you never know how things will go. So we like to have that completed. And then the second one is a letter of anticipated death. So if we're anticipating that someone's going to die at home, we have to have this letter in place to support that. So if someone were to die at home without the letter, then it is a reportable death. In other words, if someone dies at home, like without having this letter, we would have to phone the authorities. If we have this letter, it negates the need to do so. So when we're expecting a death, it's nice to have in place so that, when someone passes away, you can spend time with family and not have to have all sort of the chaos of calling 911. So it's completed by the doctor, and a copy is sent to the medical examiner and your chosen funeral home. And at the time of the death, the family calls the funeral home, and there's no need to notify the authorities. So that's one of the documents that we like to have in the home. Just make a nice transition at end of life. And that's kind of a the hard and fast summary of palliative care. We cannot change the outcome, but we can affect the journey. It's a lot of information, so I suspect we'll have some questions, and maybe Okichi can jump on and help me answer some.
Well, first off,
Thank you, Danielle. That was very, very well done. It was presented in a manner, I think, that's very respectful to everyone involved. Because we all are getting to that point in time in our lives where this is going to be a part of our journey. I would just make one comment, and I can't emphasize this enough, going through it, with several family members. Everyone, no one is more important than the patient, but every patient needs to have an advocate. That is so critical to this whole process, because you talk about people that are grieving, people that are going through some difficult circumstances. So it's always good to have an advocate. In our family, it was usually my wife or one of my sisters or whatever, but there needs to be an advocate, because these individuals, this care team, they're doing everything they can. They're very comforting, they're very caring, but you also need an advocate on your behalf as well.
Yeah, definitely.
can you unshare the screen?
Oh, sure, I can. That's a good
Sorry.
idea. Did I do that or
That's-
someone else?
No, you can do that, because
Uh,
I've lost my full
I
screen.
think you're sharing. I'm not seeing my screen anymore. I think I'm seeing your screen now.
Okay.
Well, you can tell Mark's
Somehow-
been
There
busy.
Here
we
we
go.
go.
Sorry, I technical difficult. Sorry, I also want to just echo how respectful and how helpful the palliative team is. I've been involved with palliative care recently, and this is one of the reasons why I wanted to bring it to the group, was because of all of the wonderful things that can be added to someone's transition. And truly the dignity and respect is a huge part of it. And it's really wonderful to see the system working how it should. And it does do a lot for family and for those in the program. So I just wanted to add that and my thanks personally.
Yeah, and thank you for bringing it forward. And it is something that a lot of people aren't comfortable talking about, because we don't want to face that part of things, right? But in reality, they say, the joke, there's only two things guaranteed in life, right? Death and taxes. So it is good to kind of talk about and to know what's out there, so that if it comes up for you or a family member, that you're empowered with knowledge, right?
So let's open up questions. Anyone? Just unmute yourself and jump in.
Okay. Do you know what percentage of people die at home with palliative care now? I heard, 20 years ago, like 10, 12%. And I'm wondering, has the attitude improved enough that the numbers are going up?
That's a really good question. I actually have a slide here that maybe I can share with you. I'll share this screen again for one quick second. Sorry, I'm just getting emails here. Can you see that?
There, yep.
Yes.
So that's the breakdown. It doesn't give us the exact numbers here, but you can see sort of the percentage of people that are dying in different
Well,
locations.
it's definitely over 30%, looking like
Yeah,
close
that's
to 40,
good.
looking like close
Wow.
to 40%.
That
Yeah,
looks good, yeah.
And because I'll just stop sharing again. Because the goal of the palliative, most people want to die at home. So that's really what the program is to support that process for people to be able to die at home should that be their wish. So I think like the majority of the patients, like I said, about 400 to 500 living in the community right now enrolled on program. And it looks like a good majority of those actually are able to remain at home through their journey. So
Other questions? One of the things that I'll mention is with home care, under the palliative program, you can also enter the self-managed care program, which allows you then to deal with a care provider of your own choosing, and you get to manage the hours that you have, up to 55 hours a week of home care, which is really helpful to have somebody there when you're not, or to be able to provide all of those things that the other person can't do.
Mhm.
So
Yeah,
that's
no, that's true, Mark. I'm not the expert in that. Our coordinators are really the ones, the quarterbacks of that. But I do know of the self and family managed care model. Um, it does involve a bit of know-how in terms of it's almost like running a, there's like quite a bit of paperwork involved. I understand. Again, not my
like
area, but
it's like
I
writing a
haven't.
grant. I'm
Yeah,
good
yeah,
at
you
it.
have to sort of account
Yeah.
for where the money's going and being able to be kind of it's a bit of a process, but I have heard it be very successful
Yeah.
for certain patients and families have found it very helpful. Yeah.
Yeah.
So, Danielle, a lot of people think that palliative care is for people that's aging. What about young people that deal with palliative care?
Well, similar to in my presentation, like palliative care is more of an approach to care. It's really focusing on comfort over trying to like disease intervention, so to speak. So
Mhm.
it can happen at any point in somebody's illness trajectory. If they have a life limiting illness, it really can occur at any time. The level to which it occur might change as things progress, but you can take a palliative approach to care at any point. I've seen people diagnosed with a cancer who have made the choice to say, I don't even want a biopsy. That's not something I'm willing to undergo. I don't want to have any um, a treatment through cancer care. I just want to focus on being comfortable. So we don't necessarily know what's happening with that cancer if it's progressing. We're not, taking the X-rays or CTs or blood work necessarily. We're just going off of what the patient says how they feel. So, if they're feeling pain, okay, well then what can we do to help manage those symptoms? Are they nauseous? Okay, how can we manage the nausea? So we're not taking disease geared interventions, just really focusing on the person. It's really person centered care.
Yeah, I think I want to emphasize that everything you've said and every part of this presentation is always focused on the patient
Yes.
for their relief, for their care. That's so critical to this point.
Exactly. It's a different approach to it's different. I mean, when I first got into palliative care, it was a shift, right? Because in my nursing education, it's very, what is their blood pressure? What are their O2 sats? What are, like all of these numbers, right? And knowing all of the investigations, their lab values, what does that mean? What am I looking for? So when it came into palliative care, it was sort of that shift where my mind maybe would go, oh, I need to check what their blood pressure is or their O2 sat. But but not necessarily, because with a palliative approach, I'm saying, well, how do you feel? Do you feel short of breath? No? Okay. So do I really need to check their oxygen saturation? Because I'm not worried about the numbers. I know the numbers might not be good, but I'm worried about the patient. So it's really is patient focused, person focused, and just walking alongside them, managing symptoms, as they approach end of life.
Thank you. Any
Yeah.
questions out there? Put up a chat or just wave your hand or speak up.
Yeah, you mentioned that you use volunteers as part of the program. Do you know anything about that?
Yeah, and I apologize. I did have my final slide was with resources, and I had a little bit of computer trouble this morning, and I think that slide did not save. So I will forward that to Martin. Some resources I'll include the healthcare directive, ACP site that you can look at, having those discussions or thinking among yourself about what level of care you might want, and maybe talking about family members about that, just so everyone knows what your hopes are and what you would like to see happen in your care. The other one was Palliative Manitoba. That's who coordinates the volunteers for they're not associated with us necessarily and not part of the Winnipeg Regional Palliative Care Program, but we work closely with them. And so I'm not sure, but I think you can self-refer, Ogechi. I'm not sure if you know that. But I'll put the link up for their website to kind of get some more information. And then virtual hospice is an amazing resource. I'm not sure if any of you are familiar with it, but I'll send that resource to Martin as well. And that's just a really great place to find almost anything related to palliative care, both for patients and for caregivers. It's a really good resource.
Great. Just put those in my notes.
Oh, Ogechi's sending the links for those.
They don't cut and paste her easily.
What's that?
They don't cut and paste her easily.
Yeah. Oh, look at her go. Awesome.
So,
She is, but you'll send them to me. Great.
I'll email them as well, but yeah, there they are.
Yeah, I'm just trying to cut and paste them and I can't get them.
Okay. I'll send them.
any comments or personal from the audience?
Wow.
I have a question, but it's not to do with palliative care. Martin, when we used to have the lunch and learning, you had had someone from WRHA, the home care program. Would it be about time to do a review on that? So I know that it has nothing to do with palliative care, but they kind of go in a fashion together.
I would say yes, but I would wait just because the system is still so stretched. I don't want to get people, what may be available is one thing, what the system is capable of supporting is completely something else. So I would wait till the fall before I would move that route.
Yeah, we should keep a notation. That's a good idea. It's a good tie-in.
It does. We really like the palliative care program. The way I describe it to people is it's sort of an add-on almost to home care. So home care is your base and it's the same whether you're on palliative care or not, you get the same service. And then when it's felt that the specialized service of palliative care is needed in addition to, then that's usually when we become involved. So it's good to get a good understanding of the sort of the home care foundation and support available.
And the case coordinator or the quarterback, they're phenomenal. My case coordinators are right across the wall from me in another office where I work in Riverview Health Center. So I get to see them work every day, and what they do is it's amazing.
Yeah.
Really it's a really good program, and I think it's underutilized. But at this point in time, as I said, everybody's stretched. It's probably a good thing it's underutilized right now.
I think the stigma as well as just the name palliative or hospice.
Oh yeah.
Yeah.
It makes people uncomfortable. That's why we have these presentations to kind of introduce people to these programs, because they affect all of us in some form or fashion.
Yeah.
Any other comments or questions?
Well, just from me again, thank you so much. I've often wondered about this palliative care, how some get it, some don't get it, how they end up in hospital, how they end up just in hospital. So it has been a real informative thing for me. And I've taken lots of notes, by the way. Not read it or understand it afterwards, but I got it down. So thank you ever so much.
Oh, I'm so glad it could be helpful. And I mean, this is our passion. So we like to be able to share it with others that are willing to listen to us whenever we get the chance. So
now, if someone is referred to the program, they don't change their doctor. Is that correct?
that's right. Yeah.
Okay.
Yeah.
So
we
who refers? The social worker or your doctor or?
Yeah, so it's your primary care provider. So usually it's it depends on the situation. We often get referrals from like directly from, an oncologist if they're involved with the patient, if it's a cancer diagnosis, because they're the ones who can better speak to, yeah, I think this person meets that criteria. I think we're, within 6 months, I think, like they're able to check those boxes. Sometimes it is from a GP, like your general practitioner or nurse practitioner, if they've been alongside for your chronic disease, and they're thinking, okay, yes, we're in that window now, so we'll receive applications from them too. Cardiologists sometimes are the ones who refer. It really depends, but it's from a physician or a nurse practitioner that receives or that sends in the application.
Mm. Okay.
I also want to highlight, you spoke about that letter of death that someone has. We went through that in our family. My relative was home on a Friday, and unfortunately, the doctor had the letter prepared for us on Monday, but he passed away on Sunday. And it really wasn't a difficult process, but I can see why people want to spend time with their loved ones alone. I will say this on behalf of the law enforcement and the other individual involved, top notch. They were
Yeah.
unbelievable, unbelievable.
And even like in those instances, having that healthcare directive, or your advanced care planning, sometimes people keep it on their fridge or on top of their fridge, just so that if there is a death in the home, at least, we're not trying to do, because without it, I believe that they have to attempt
It's
resuscitation.
mandatory. It's
Yeah.
mandatory.
Yes.
So it's important to have those documents. And then if we know that we're planning end of life and we want end of life at home, having that letter can really make the difference, because
Oh, it's a big difference. And the great thing about it, at least the individuals we dealt with were professional and caring and very empathetic through the whole process. But it is
yeah,
a time you want to be alone.
yeah, having that time sort of just to be with the person and not necessarily have to have the neighbors because the sirens are coming down the street. You know what I mean? It allows for a more peaceful transition when possible. But yeah, so it's important.
Dignity and respect. Those are the two words that just keep coming to my mind, which
Yep.
is such a wonderful thing.
Yeah, definitely important.